There we go. So I'm just going to be, I know you guys can see a black bar up the top. I did spend a bit of time trying to resolve that before coming in, but there's nothing I could do about it. Apparently it's a common problem with sharing your screen on Zoom. So hopefully the slides are still viewable. So as we get started with this presentation on supporting your ADHD child to navigate their world and understanding and advocating for your child's unique needs, as we're going along in the info, I'm happy for you guys to pop any questions you have, I guess, around the content and what I'm sort of talking about in those slides in the chat box. It's just me here tonight, so I'll do my best to sort of flip between both looking at the chat and navigating my slides. And then we'll have lots of time at the end, hopefully, for any kind of questions that come up. When we get to the end of the slides, I'll stop the recording. So if you have any more specific questions that you wouldn't be comfortable for strangers to see or to hear, or any specific questions about like your child, for example, I would ask that you maybe hold them to that point and they won't be as part of the recording. All right. So I'm going to start off with an acknowledgement of country. So we're all virtually gathered tonight and distributed across different locations. We acknowledge the traditional custodians of all the unceded lands, skies and waterways, and pay our respects to elders past, present and emerging. I'm going to do a little introduction to myself. So my name is Meg, as you can see in my info. I am a registered play therapist as well as a registered play therapist supervisor, which means I get to do both working directly with clients and families as well as supervising other play therapists, both as part of the Masters of Child Play Therapy course at Deakin, as well as graduated working play therapists. I also work as an academic and have done a bit of research in the play therapy space and do some marking and some other academic work at some different universities, mostly to do with play therapy. Prior to going back to university to study to be a play therapist, I worked as an early childhood teacher for about 10 years across a number of different settings in Victoria, both regional and here in Melbourne. Really loved that job. I got to work with lots of neurodiverse kids in that time, which really, I guess, drove some of my passion to go back to university and learn more about how best to support children with a range of different presentations and needs that I was working with in my teaching role. And very importantly for tonight's presentation, I have ADHD. I'm also neurodiverse or neurodivergent. And so a lot of the things we're talking about in regards to what might be happening for people's children are also things that apply to me, both here as a picture of me as a child. Some of these things were definitely present for me at that age and are still very relevant to my life now as a ADHDer, navigating existing in the world and work and all the things that come along with that. Just going to check no one else is in the waiting room. Oop. Let me see how I can navigate across and check. I think I got to pause sharing and I can do it. Nope, I think I'm okay. Yep, good. Okay, go back to the slides. Drop down. There we go. Okay, so before we get started with tonight, I'm just going to give a little bit of an overview about what play therapy is, as I know some people who are joining us are existing clients of ours at Playroom Therapy or might be previous clients, and some people are joining us from different community organisations we've been involved with, and some people might just have seen our posts on Facebook or other social media. So I just want to give, I guess, a bit of an overview about play therapy and what we do at Playroom Therapy. So play therapy is a developmentally appropriate and evidence-based method of counselling. In play therapy, children can play out literally or metaphorically their inner and real life experiences in a way that builds insight and capacity. Play therapy allows children to express, regulate, communicate, practice and master new skills within the context of a safe therapeutic relationship with their play therapist. Play therapy is child-centered and child-led, and it's neurodiverse affirming and recognises the rights of children to express themselves in ways that best align with them and what they would like to be like. Generally, play therapy is used with children around 3 to 12 years of age, but it can definitely be used with children who are older or younger than that as well. I've worked with children definitely who are younger than 3. Children might attend play therapy for support with their emotional regulation and big feelings. They might attend for support with building self-esteem. They might attend for processing traumatic events or life changes and challenges like parent separation, loss of a pet or a relative, upcoming medical procedures. They might be starting school or kinder. They might have a new sibling in the family. They might need some support with building social connections and forming friendships. There are lots of different reasons why children attend play therapy. In regards to Playroom Therapy specifically, we have 2 clinics. One's in Baldwin North and the other's in Melbourne East. We offer a number of types of therapeutic approach at our clinics, including individual play therapy. We run group programs, which I'm a part of and really love. We also do intensive group holiday therapy programs, which I also am a part of. We run parent workshops and we do training for schools and kinders. So we do lots of different things in our clinic. Check again. Yeah, all good. So what are we going to talk about tonight? We're going to talk about what neurodivergence actually is, or what that term means. We're going to touch very briefly on what the models of disability are, because that helps, I guess, set the sort of groundwork for the information I'll be talking about. I'm going to give an overview of what ADHD is, and then we're going to talk about neurodiverse affirming parenting and strategies, which is, I know, what everybody is here for. I'm going to give you some things to take away with you to look for further information if you'd like some, and then we're going to have time for questions. So to start off with, we're going to define neurodiversity. So the concept of neurodiversity is more easily understood when we break the word down into its parts. So simply put, neuro, which means relating to nerves or the nervous system, and diversity, which means differences or things that make us unique. When combined, it's neurodiversity. So it's you can think of it in essence as different ways of being or thinking or existing in the world. It's, as it says up there, neurodiversity talks about the natural diversity of human minds. And it's a biological fact that we are diverse in our minds, just like we are in lots of other ways in our lives. When we talk about neurodiversity, we are talking about lots of different ways of thinking, learning, and behaving. The term neurodiversity was coined in a paper presented by an Australian sociologist, which I think is really cool that term came from Australia, Dr. Judy Singer from 1998. Her work in the neurodiversity pioneering field has ignited the greater conversation around the idea that like societal influences are one of the main obstacles to I guess, for people who think differently or neurodiverse people. Neurodivergent people experience and interact and interpret the world in unique ways. So neurodivergent can be thought of as an umbrella term for anybody who has a mind or a brain that diverges from what we see culturally as typical or standard or the norm. So there are lots of things that fall under the neurodiversity umbrella. Often when we talk about neurodiversity or we hear other people talking about it, when mostly people mean ADHD or autism, but lots of other things come under that umbrella. So like, as it says there, like dissociative identity disorder, Tourette's, acquired brain injury, like different learning disorders like dyscalculia or dyspraxia, OCD comes under there, and there's lots more as well. So when we talk about neurodiversity, approximately 1 in 5 people will be diverse with something that falls under that neurodiversity umbrella in their lifetime. So it's quite common, I guess, to diverge from the norm in some way or another. Whether this be in our attention, our functioning, our mood, how we process things, our learning, our behavior. It might be a genetic thing about us. It might be something acquired, like an acquired brain injury. We might become neurodiverse later in our life. Or it could be a neurodevelopmental space, which is what ADHD and autism fall under. Okay. I'm going to talk quickly about the models of disability. So there are 2 main models of disability that you might see mentioned in the space, I guess, of disability. There's the social model and the medical model of disability. So the medical model of disability talks about ADHD as a health condition that's dealt with by medical professionals. People with disability are thought to be different to what is normal, or they might be considered like abnormal, essentially. Oh, I can see someone coming into the waiting room. Great, popped up, so now I know that that's going to happen. Yeah, so people who with disability are thought to be, I guess, different to what is normal. Disability is seen to be, I guess, the problem of the individual, as you can see in this sort of picture here. So the individual is the one that needs to be responsible for fixing themselves to fit into the broader society. And so this medical model views things like autism and ADHD as problems with the individual that need to be changed. Whereas the social model of disability talks about disability as being caused or impacted by the way society is organized. And so when we think about ADHD and autism from a social model of disability lens, we're thinking about the ways that having a brain that diverges from the norm might have more barriers in society for being able to, I guess, fully engage and function at the highest possible level. So the social model disability makes an important distinction between impairments and disabilities. Impairments can be thought of as functional limitations as an individual. For example, lots of things we're going to talk about ADHD are like functional impairments that do make things very challenging for children and adults with ADHD. However, if we have a lot of support, these things aren't always going to be disabling. We're going to be able to have really successful functional engagement in lots of different domains if we have the right supports in place. Hopefully that makes sense. All right, I'm going to get into ADHD. So I'm going to go over a little bit around what ADHD actually is. I know that the people who are here whose child has maybe been diagnosed with ADHD, some of this you might be familiar with, and some of it might be new. I know lots of people who go off to the pediatrician or the psychiatrist and are diagnosed or have their child diagnosed don't always receive a very thorough explanation about ADHD. So I always like to cover this sort of stuff in these presentations. I used to joke that I wish they would give you like a pamphlet. So your child has ADHD and they would give you all this information to process, later when you're not so overwhelmed in the moment about hearing what's going on for your child. So think of this as, I guess, as your pamphlet of information about ADHD. So at the moment, there are 3 different types of ADHD present in the DSM-5. ADHD is a complex neurodevelopmental disorder which affects a person's ability to exert age-appropriate self-control. It is characterized by persistent patterns of inattentive, impulsive, and sometimes hyperactive behaviors, and is frequently accompanied by emotional regulation challenges. That's the definition from ADHD Australia. You can see someone's asking me a question. I know there's a black thing up. Yep, Vanessa, we are definitely recording. You'll be able to see it afterwards. ADHD is thought to be related to an issue with producing dopamine. Something important that I like to cover is that ADD is no longer given as a diagnosis. I know when I was growing up, that was still in place, that people were diagnosed with ADD or ADHD. But when they did the most recent version of the DSM, they instead went into these 3 subtypes of ADHD rather than having ADD anymore. They all fall under the umbrella of ADHD, sorry. There are 1 in 20 people will be diagnosed with ADHD in their lifetime. So it's reasonably common. ADHD is not something that children grow out of generally, which is again something that a bit of a shift in thinking around ADHD since when I was younger. ADHD is also thought to have a strong genetic link, and one of the most common times for a woman to be diagnosed is actually after her child is diagnosed. And so often parents with ADHD will have children with ADHD, or you might find multiple people in a family that have ADHD similar to autism, which also has a strong genetic link. There is also thought to be some gender differences in how the ADHD is presented, and you might see quite a lot of media at the moment or in the last year or so about the influx of girls and women being diagnosed with ADHD, and that's really representing, I think, a shift in how we understand ADHD and its presentation. The diagnostic criteria in the DSM-5 are all based off a typical male presentation of ADHD. And so as we learn more about ADHD and how gender might play a role in how that presents in different people, we're seeing more girls and women being diagnosed with ADHD as that understanding grows. So we're going to talk a little bit about the 3 types of ADHD. The first one's hyperactive. So people with hyperactive ADHD might be the type of people who are fidgeting and tapping, and they might be wriggling, moving their legs, and generally moving around a lot. They might talk excessively. They might blurt out answers or interrupt others. Children might be making loud noises or narrating their actions. They might respond quickly to situations without anticipating the consequences. So they might make quick or rash decisions or rush in without waiting to hear all the instructions. They might really badger or bother their parent or friends when they want something. They might find being bored intolerable or constantly seek stimulation. They might participate in more risk-taking or dangerous behaviours. They might find delayed gratification really tricky. So they might choose a small reward now rather than postponing and getting a bigger reward. When we talk about hyperactivity, this is one of the spaces where there might be differences in presentation based on being a girl or a boy. So sometimes when girls are diagnosed with hyperactivity, it might not look like outwards hyperactivity, but they might have really busy racing minds. So they might be the kind of person or child that's lying in bed and all their thoughts are kind of getting on top of them. That's much more what my hyperactivity looks like rather than physically moving around a lot. So it could be hyperactive internally as well as externally. The other type is inattentive. So people with inattentive ADHD might struggle to focus and concentrate on information or tasks, particularly if they find them boring or tedious. They might experience mind wandering. So this might be real daydreaming people. And they might be frequently interrupted by unrelated thoughts to what they're doing. They can be easily distracted by external stimuli. They might miss instructions or relevant information because their brain is so busy. They might have trouble remembering information. They might struggle to pay close attention to detail and make careless mistakes. They might fail to finish their tasks or achieve their goals because they've gotten distracted along the way. These are the kind of children or adults who lose things a lot. They might avoid or seem reluctant to engage in a task that requires sustained effort. We'll talk a little bit more around what that might be later. And then the third type of ADHD is combined, and that just means that you tick the box on enough of the other two types of hyperactive and inattentive to be able to be diagnosed with combined. It's just a combination of the other two types. Not everyone who is diagnosed with ADHD will be told which type of ADHD they have. Sometimes you're just told, yep, you have ADHD. But these types are part of the diagnostic criteria and they are part of the DSM. So when you are being diagnosed, the person doing the diagnosis will know which one you're falling under. They just don't always tell everybody that. Sometimes being diagnosed or having a child diagnosed can be a real space of both being relieved and feeling grief around the diagnosis. You might feel relieved to know what's happening for your child or for yourself receiving that diagnosis. It might be like, oh, finally an answer to why this has been so tricky for such a long time. But there also can be a sense of grief, and I talk a lot about that with people who are diagnosed, newly diagnosed, to know, okay, what does this mean for me? What does it mean for my child? This is going to be forever that we're going to find these things hard. It isn't just that I'm going to be able to one day magically wake up and be able to do the things that I'm finding really tricky, or my child is not always going to be able to do the things that they are finding tricky. It's never maybe going to get easier. All these kind of thoughts can be happening for people when they receive that diagnosis. So I really want to name that sometimes it can be good to know what's happening, but it also can be a really scary and sometimes even sad thing to find out about. The spectrum wheel. So although I just talked about those three types of ADHD, some ADHD researchers and advocates have suggested that ADHD is actually better represented on a spectrum, very similar to how we view autism. The concept of spectrums for ADHD, when viewed in this manner, are more aligned with the idea that each person is different and that their diagnosis will be unique to them rather than falling into set categories. So when I read that a child has inattentive ADHD, that doesn't really tell me that much about how that presents in that person. And so yes, they might have all the things I just said as part of the diagnostic criteria, but I really want to know what's going on for that unique person, and using this sort of spectrum wheel can really help to be able to visualize uniquely for that person how it looks. This model aligns itself more closely with that idea of the social model of disability, as it sees each person as unique with different strengths and challenges that might need support. We also can visualize ADHD in this way to represent concepts like fluctuating capacity and having a spiky profile. You might see people use those terms. So a spiky profile is when there might be a big difference in someone's level of ability in one area to another area. So you might be really good at doing one thing, but then really struggle with something else. Maybe you're great at interpersonal skills and you don't find that challenging at all, but you might then really struggle with getting your homework done. So that's, I guess, a spiky profile, really different levels of ability. You might be an amazing story writer, but find it impossible to stay on top of cleaning your bedroom. The reason that we talk about spiky profiles can mean that both children and adults are either overestimated or underestimated based on what people see of your profile. So if you're really good at staying on top of your paperwork, for example, people might be like, oh, well, I don't think you have ADHD because I never see anything. But then you get home and your place is a mess. Maybe a bit of a self-insert here. That might be my spiky profile coming out. And so people might be really surprised to learn that you're struggling or have ADHD. Similarly, people might see you, for example, at school, really struggling to stay on task and to focus. And so they might underestimate what you're capable of if you were given different opportunities. For example, to be in a leadership role, you might really excel in that space. But teachers might have seen you, struggling to stay on task and interrupting and all those things. And they might be like, oh, we're just going to not give those opportunities because it doesn't seem like they're capable of it. But actually, we know that people have fluctuating capacity or spiky profiles. We talk about fluctuating capacity. We're also talking about how people with ADHD or other things going on for them might have different capacity for tasks that change day to day or over time based on overall functioning, how busy their life is, or different events that might be going on for them, how regulated they are, and how many supports they have in place. So sometimes we see children with ADHD who cope really well at the start of a term after they've had a bit of a break and some downtime at home. But by the end of the term, they're way back down to the bottom of their coping capacity. And so they're fluctuating downwards in their capacity. And so that can be helpful to be aware of, particularly when you're planning. If you're able to plan ahead around things, I might not do as many big brain things towards the end of the term, for example, if I was a teacher, if I had children with that fluctuating capacity. Something that's really important to note, I think, particularly for parents of girls, and if there's any parents of teenage girls here, something that we know from research is that periods or changes in hormones can make symptoms worse, particularly for ADHD. This is, I guess, an emerging area of research and something that also can lead to that fluctuating capacity. So I always like to mention that when I'm talking about that fluctuating capacity. All right. Talk about one of my favorite topics, executive dysfunction. So we can think of executive functioning as the conductor to your brain orchestra. And executive functioning, when we talk about it, encompasses all these skills here. So flexible thinking, working memory, self-monitoring, planning and prioritizing, task initiation, organizing, impulse control, and emotional control. I often think about the scenes from Inside Out, I guess all those sort of emotions working together. Executive functioning is essentially that kind of concept, all these different skills in your brain working together to keep you sort of on track and doing the right thing in the right moments. A shared experience amongst people with ADHD is experiencing executive dysfunction, which means that some or all of these areas are impacted and not working at their best. A common experience of people with ADHD is time blindness, so difficulty telling how long something will take or how long something's been going on for. There's often difficulties in breaking down the steps of a task or knowing where to start the task. So these might be the children that you say, oh, go and do this in your room. And then you go in there and they haven't done it because they've been unable to go, oh, firstly, I need to do this part and then this part, and then I'll be able to do this. Difficulty knowing where to start a task. They might have poor working memory, so difficulty sort of holding something in their mind, keeping that key information in your mind to be able to use it. They might have difficulties with emotional regulation. We're going to talk a lot about that later in the presentation. They might have challenges with staying on task or knowing what to prioritize. These are the kind of children you might see at school who are getting off track all the time and not understanding, oh, hang on, we're supposed to be working on this thing first and then this thing. They're not sure which thing is more important. We can think of executive dysfunction as there being no one at the controls of the ADHD brain to slow things down or to pause and think before doing things. And so this can lead to lots of different challenges for children and adults with ADHD. Lots of people talk about executive dysfunction as like the main part of ADHD that they find challenging. Okay, we're going to talk about medications. So I again like to cover this in case there are people in here who don't have a diagnosed child. Oops, someone else is coming in, just going to admit them. So, yep, sometimes people might already have a child in their life that is on medication, and they might have tested out a few of these ones. But if not, I'm just going to tick off a little bit around each of these medications. So many people with ADHD will be prescribed medications for their ADHD. This can be a tough decision for parents and adults with ADHD about whether to go ahead with the medication that is prescribed or that might be discussed by the pediatrician or the therapist. For some, medication can be really life-changing, and for others, it might not be life-changing. I take ADHD medication and it hasn't been as life-changing as it might have been for some of my friends who have ADHD. For some, medication can give a lot of side effects, and so some children and adults might try medication. It might not be something that they take to or stay on, and they might choose to stay unmedicated. Each person gets to say what feels okay for them. I would never, even though I take ADHD medication, I would never tell another person that they definitely should take ADHD medication. I think it's a very personal choice for parents and for adults with ADHD about whether they feel comfortable taking medication. Medications prescribed for ADHD fall under two categories generally. There's stimulant medication. So there's short-acting stimulants, which often most commonly are Ritalin or dexamphetamine. And there's also long-acting, which is Vyvanse and Concerta. They're both just long-acting versions. So Concerta is a long-acting version of Ritalin, and Vyvanse is a long-acting version of dexamphetamine. And there's also, I think, Ritalin X or something. It's like another long-acting version of Ritalin out there as well. And then there are also non-stimulant medications, which are the most common to are Strattera and guanfacine. And so you might see, or you might talk to, I guess, your pediatrician, if you have a child, might talk to you about these different options. Common side effects to medications, and particularly stimulant medications that might impact on children, can be nausea. You can experience a feeling of anxiety when you start taking medication, particularly with the stimulant medication. So even if you aren't actually anxious, your body can feel anxious because it's speeding up your nervous system. You might have difficulties regulating your body temperature. You could be very sweaty. You could be getting very hot. You might have difficulties eating. Stimulant medications often have an appetite suppressant element to them, and so it might be tricky to eat when you're taking the medication. You might need to eat when taking the medication, however, as it might make you feel that nauseous feeling. You might feel sick taking stimulant medication and not eating or having anything in your tummy. You might have issues when the medication wears off. You might have a rebound effect. Particularly, we see this often in long-acting medication, so Vyvanse or Concerta, when children often take their medication and come home from school, their medication is wearing off, and they have this big rebound effect sometimes where children are very emotional and I guess adjusting to that transition period between home and school can be tricky when that's also when the medication's wearing off. They also could have issues with sleeping when they're on stimulant medications, and you might see more moodiness or mood swings, particularly when they're first starting adjusting to a dose of medication. They also might experience things like grinding teeth or tics or physical body movements, again, as their nervous system sort of gets used to this stimulant medication. So just like to mention all those side effects, as sometimes they can go away and they can be really tolerable. And I had some of those side effects and they've all kind of subsided. But there also can be that these are reasons why people might decide not to take the medication or might not stay on it after they start taking it. We're going to talk about neurodiverse affirming parenting. So again, you might have heard the term neurodiverse affirming. It's becoming much more popular than it used to be to talk about how different things are neurodiverse affirming. And this is the neurodiverse affirming paradigm, I guess, represented here with this infinity symbol, and talks about all the different elements that are needed to be neurodiverse affirming. We want to presume that neurodivergent people are competent. We want to promote autonomy. We want to respect all different types of communication, be informed by neurodiverse or neurodivergent voices. We're taking a strength-based approach when we work with neurodiverse people. We want to honour neurodivergent culture, and we want to tailor our supports to individuals. So again, thinking about that way of looking at ADHD as unique to each person rather than just saying, oh, they're inattentive, so it has to be like this. To be neurodiverse affirming in our parenting practices, we must begin with acknowledging and fostering the belief in ourselves that ADHD is not something inherently wrong with somebody, which can be challenging to sit in that space, particularly with all the challenges that come alongside parenting a neurodiverse child or an ADHD child. That we can move instead to thinking about it's just a different way of being, and that our child just needs different supports. ADHD children don't need to be fixed, although they might require support at times, just like any child might. And they have lots of wonderful things about them that we can celebrate alongside supporting them. Within this, we can acknowledge the challenge that comes along with parenting a child whose brain is wired differently, and that many in our world might view as naughty or making a choice to be that way or defiant, or that ADHD is something to be changed or suppressed. I often have parents talk to me about school wanting them to medicate their child, for example, so that there's not the challenges occurring in that setting and the pressures that might come along with that discussion from a school. Parents of neurodiverse children often need to become their advocates in different situations, whether this be at kindergarten or school, amongst family or friends, or in the broader community. This can look like educating those around our child and advocating for strategies and therapies that align with the core belief that ADHD children don't need to be fixed, they just need support with different things. Parenting a child who has different challenges to those of their neurotypical peers can be really isolating at times. It can be really different to parent a child who has these challenges. And so I always encourage parents and people with ADHD in our community to connect with other parents who are going through something similar and learn from other neurodiverse community members, as this can be one of the most important aspects that parents can do as part of their journey, and knowing that, although we have these challenges and although each child is unique, we're not alone in finding this challenging. Why is this important? Why am I so passionate about talking about this? So we know that there's a high amount of stigma misinformation around ADHD, as I just mentioned, can be thought of as a choice, or a choice to be naughty or defiant, or often people worry that it's reflective of their parenting. There might be a misconception around that in the community. And so with this high amount of stigma and misinformation, this can lead to shame for children and their families when they're diagnosed or have ADHD. Children with ADHD will receive on average 20,000 more negative messages about themselves by age 10 than their neurotypical peers, which is really awful. Like 20,000 more negative messages, either directly or indirectly, from people around them. And that, as you can see under that, neurodiverse adults are more than 30% more likely to be diagnosed with depression or anxiety. So a lot of my work working with neurodiverse kids is often about building up their self-esteem and saying, hey, actually, you're great, even if you're hearing those negative messages from the community around you. There's a common public misconception that having ADHD is linked to intelligence, and we know that that's not true at all, which can lead to self-doubt for ADHD people. A recent study also found that 75% of neurodiverse children had been left out of activities by their peers and classmates. They were not invited. And about 32% of families with neurodivergent children had been excluded from social events, and 40% of families with a neurodivergent child had isolated themselves and had chosen not to go to a family or friend event due to fear of judgment around their child or around their parenting. So again, really important to acknowledge that this does have a big toll both on children and their parents. And we're all, I guess, doing our best to educate and to advocate that there's nothing wrong with ADHD children, and there are lots of misconceptions out there. But unfortunately, we still have more work to go in that space. All right, and talk about some areas of accommodation. So how can we support our child with all these things going on? I've organized, I guess, our support ideas or our areas of accommodation into 4 headings: sensory, social, emotional, and executive functioning. As I mentioned earlier, everyone is unique. Each child's needs are unique, and not all strategies or concepts will apply to everyone. If there are any specific support ideas, these should be, planned alongside the person if possible, and I guess, discussed with their team that's involved with them. But there can also be, common strategies that might be helpful for lots of people with ADHD that I'll talk about. I'm going to pause and make sure I'm not missing anything on the other screen. Nope, all good. Great. Okay. Our first area is sensory. So experiencing sensory seeking or being sensory sensitive, which is a bit of a mouthful, are common experiences of people with ADHD. Oh, I feel like I'm in the wrong window. There we go. Sometimes our child might be sensory seeking. They might want lots of sensory input, and sometimes our child might be sensory sensitive or sensory avoidant, you might say it called, which means that sensory input is a bit overwhelming and they can experience that sensory overwhelm or sensory overload. And we're going to talk about meltdowns and things like that in a minute. And so sensory issues are a result, can be over-processing sensory input, being sensitive to it, or under-processing sensory input. You need more sensory input than you're getting, or our sensory input might be lost in transit. We might have a low registration of sensory input. So we can think about ways to both increase sensory input for our child or decrease sensory input if they're the kind of person who's sensitive to sensory input. And they might have, again, have that fluctuating capacity. Sometimes they might want lots of sensory input to really rev up that sensory input and get themselves going, but they also then might experience sensory overwhelm if they get too much sensory going on. So it can be tricky to find a balance between the two. So some ways we can think about supporting our child's sensory needs are around sight. So thinking about the types of lighting that we have in our home or in our schools and whether we need to reduce lighting. I have the big light on today in my house, so I'm doing this presentation, but I often don't have my overhead lights on. I have a lot of lamps in my house. So if I'm in a sensory sensitive space, I'll turn off the big overhead lights as they might be a bit tricky, a lot of input. We might try and avoid visual clutter for children who have a high sensory sensitivity. We might not too many things in line of sight, again, because all that processing and information is coming in and it's overwhelming to know what to pay attention to, and our brain might be getting, or our nervous system might be getting dysregulated. You can think about touch. So we might want access to sensory items like fidget toys, weighted blankets, alternative seating options like bean bags or wiggly chairs, having like, I guess, capacity to get up and wiggle around at places like school or at home. We can think about the type of clothing in terms of touch. So making sure that things we're wearing might be comfortable, not too tight or not too hot, not having tags on them, for example. Or as I said about the weighted blankets, we might really like the feeling of being constricted and wrapped up. And so some children who are sensory seeking really enjoy that sort of deep pressure feeling. Smell, it might be helpful again to avoid having overwhelming scents in the space. These are the kind of children that you maybe wouldn't want to have like an air freshener or a candle going. That might be really overwhelming for sensory reasons. Or there might be children who really like sensory smell input for sensory seeking. So those are the kind of children that might really like having access to like perfume or deodorant that smells nice, and they have, giving that a bit of a sniff and getting that sensory input. But you can think about temperature as another element of sensory. So I guess as much as possible, making sure that we're environments that are not always in extreme heat. These are the kind of children that might be in a classroom where it's really hot during the day. And I know lots of classrooms, for example, don't have air conditioning. They might just have the fans, and that might be causing some sensory overwhelm. Or children who, might be in other settings that are really cold and have the air conditioner on blasting. And again, that might be a bit tricky if you've got that sensory sensitivity. You might use items like blankets and fans to support sensory regulation for temperature, wearing the right kind of clothing for the weather. Another element of ADHD that often presents, particularly in children, is difficulties with interoception or knowing how your body is feeling. And so often these are the kind of children where they are obviously too hot or too cold, but they're not able to sort of pay their mind to that. They might not be very aware of how their body's feeling. And so tuning in and checking on those children to be like, hey, I can see you're really hot and flush, but you've still got your jumper on. How are you feeling? Oh, too hot. Okay, let's take your jumper off. As they might be, I guess, getting into that sensory overwhelm and they are too hot and they're dysregulated, but they're not able to sort of recognize why that's happening. And it's very similar with things like eating and drinking. These are the kind of kids whose brain is so busy, and particularly these are the kind of kids who might be at school all day and not eating or drinking anything. Their brain is super busy, and so they can't pay attention to how their body's feeling. And their body's telling them, I'm really hungry, I'm really thirsty, but their brain's just not picking up on those messages. They're too busy doing other things. And so they might be coming home and going, oh, I haven't eaten anything all day. I'm starving now. Super thirsty now. Similarly, going to the toilet and knowing that you need to go to the bathroom is another message that your body and your nervous system are sending to your brain that some children with those busy brains with ADHD don't pick up on. And so it's important, again, to do some checking in and for different services and settings that children are in to make sure that they check in and say, hey, how's your body feeling? I can see you wiggling. Do you need to go to the toilet? Oh, right, cool. We're checking in. Great. I'm going to go to the toilet. Another area can be around sound. So again, if we're sensory sensitive, we might want to have noise cancelling headphones, or if we're sensory seeking, we might want to have music going, get more sensory input. I often need a lot of sensory input of noise to help myself concentrate. So I'm putting like the same song on repeat, and then I'm really able to get in and focus. But when I go to the supermarket, I need sensory noise cancelling headphones on because it's too overwhelming otherwise. We might want to have quiet spaces at school or kinder or at home that are away from noisy areas. So often I see in classrooms like a little sensory area set up in the tent, for example, but it's in the classroom. And so, yes, we could go inside the tent, but if there's no noise cancelling headphones or other barrier to noise, we're really still being able to hear all the noise in there. So really making sure that we're able to withdraw from noise if it is overwhelming can be really important. And making sure that places do, I guess, honour a child's need to withdraw if they are getting overwhelmed from sensory input and are able to access really low sensory environments can be really helpful with this element. Oh, I did not want that to come up on the side. Okay. We talk about stimming. So stimming can look like lots of different things. It can look like, it's, I guess, repetitive body-based movements generally. It's a good way of describing what stimming is. And it's a normal way for neurodivergent people to regulate their body and keep their body calm and able to concentrate. So there's a few reasons there on the side why. You might see people or children with ADHD stimming. So it might be to cope with restlessness due to hyperactivity. It might support with anxiety and reducing that. It might distract from boredom. It might handle like stress, again, from masking ADHD symptoms. So again, a bit about anxiety. It might help with controlling impulsivity. It might be expressing happiness. And your body feels overwhelmingly happy and you need to sort of get that out physically. It can enhance creativity and it can express frustration non-verbally. So it can look like lots of things. It can look like tapping, humming, joint cracking, repetitive different things, hair twirling. It can be verbal, so saying things over and over or making sounds over and over, jumping, hand flapping, spinning, can be staring off into space. I fidget a lot with my earrings and my necklace, for example. So any, I guess, sort of repetitive thing you see a child doing a lot of, or an adult if you've got ADHD, can be stimming. And it's really important that we allow people to stim so that we're not, I guess, putting that undue pressure on their nervous system. If they're trying to sit still and not do that at all, that's taking concentrated effort to not meet that sensory regulation need, and also can then lead to overwhelm. And it's really, I guess, important to advocate for different capacities to stim in different environments. Obviously, sometimes children can develop stims that are not appropriate for different settings or might be harmful to their body or to them. And so we can think about other ways to meet that need through different stims rather than trying to not stim at all. I guess alongside this, it's really important in different settings and to advocate when your child goes off to school and kinder that focus and attention don't look the same for every person. And so just because a child is doing something like stimming or wiggling, moving their body, doesn't mean they're not listening or paying attention. In fact, often it means that they're more likely to be able to pay attention because they're meeting that regulation need, keeping their body regulated and not flipping their lid. As I'm talking about, whole body listening. So this is a common expectation of teachers and sometimes therapists might place on children. You might have come across this in my teaching background. It was very popular to talk about whole body listening. And this sort of talks, I guess, about how children's bodies should appear like they're actively listening. It has that, I guess, expectation of what it definitely needs to look like. It's important, I think, to note that the person who came up with whole body listening actually didn't intend for it to be utilised and spread in the way that it has. And has actively spoken out against the way that it's sort of been rolled out to use with all children in all settings. So whole body listening demands things like your eyes are looking at the speaker, you're facing the teacher, for example. You have quiet hands, so your hands might be, in your lap or by your side. You have quiet feet, you're not wiggling in any way, I guess. You might be having your legs crossed as part of that expectation. Keeping your body still, you're not talking or moving your mouth. And adults who teach this are communicating that unless your body is completely still and you're looking at the person talking, you're not talking or doing anything with your body, then you're not being a good listener. And this really, I guess, goes against what we know of people who are neurodiverse and people with ADHD who need to wriggle and fidget and, move their bodies in ways that feel good for them to be able to fully engage and listen often. So we need this kind of sensory stimulation to be regulated. And we know that to be able to engage in learning in our highest capacity, we need to be regulated. That's across all children and adults. We need to be the most regulated we can be to be able to do that big thinking and engagement. And so the effort that a child with ADHD may need to put into keeping still, looking at the person, keeping their hands in their lap, etc., means that all their focus might be being taken up by doing that, and then actually no information going in, because the whole time I'm going, oh, I've just got to keep my body still, just got to look at the teacher. Okay, really focusing on that, not hearing any other information that's going on. And this also can then lead to potential dysregulation because they're suppressing their nervous system's needs and their natural seeking to engage in self-regulation. They're pushing that down. And so then we might see that big crash when we get home, for example, because we haven't had our needs listened to during the day. So if I had a child that was in a situation where people were talking about whole body listening, I would be talking about how to meet that child's needs uniquely for what they need, including maybe being able to wriggle and saying that doesn't mean that they're not listening. In fact, often the opposite. Emotional is another area of supports. So as I said earlier about executive dysfunction, part of the job of executive functioning is to support our emotional regulation. And so if we have challenges with our emotional functioning, we know that extreme emotionals or extreme emotions can be common. So we might have a low emotion or flat affect. We might have delayed processing of experiences. So we might not feel sad or have an emotional response till much later. We might have really intense emotions, which can include things like hyper empathy, being really empathetic or really feeling the pain of other people. There might be heightened emotions towards things like animals or inanimate objects, really high levels of empathy and emotions. We might have lower capacity to mask or hide our emotional responses, again, because our executive function is not telling us, hang on, it's not appropriate to cry about that here. Or it's not appropriate to show that you don't like this thing you're eating. Like, that's not going through that message. And so we might have these big emotional outbursts that are not appropriate in different settings. Our outward expressions of emotions can change quickly when there are changes in the environment, routine, or experiences. So we might go into a meltdown or have a big emotional response when there are sudden changes or changes in environment that we didn't expect. We might see children who have difficulties with emotional regulation and children with ADHD have meltdowns. And so when we're talking about meltdowns, it's helpful to think of them as a natural nervous system response to overwhelm and experiencing sensory or emotional flooding. So again, it can be easy to think of meltdowns as, I guess, a negative or a choice that someone's making, but we know that it's just our nervous system going into overdrive, and it's a natural response to that occurring. So during a meltdown, our body enters fight, flight, freeze response, similar to what we might see in someone with PTSD who's being triggered and having that sort of emotional flooding, overwhelm happening. And the meltdowns might be externalizing. So I might see people throwing or yelling, crying, running away, which is, I guess, really that flight response. Or we might see internalizing. So that's that, I guess, that shutting down, hiding, being nonverbal, curling up in a ball kind of reaction. And that's more of that freeze response for our nervous system. It's important to advocate for your child or yourself if you're having a meltdown. Again, it's not a conscious choice that person is making, and it's not a behavior that requires punishment, but something that requires support and understanding. You'll see that there's a couple of long-term strategies which are around having predictable routines, supporting with time management, having visual schedules, and building executive functioning to support with that emotional regulation, and having long-term goals around supporting emotional regulation and building executive functioning skills can reduce the amount of meltdowns we see in children. But as I said, when our nervous system is in fight, flight, or freeze, we're going to see some emotional flooding in a response to that happening. We talk about rejection-sensitive dysphoria. So rejection-sensitive dysphoria is not a formal diagnosis, but rather it's considered a common manifestation of emotional dysregulation and is often seen in people with ADHD. So you might see it mentioned in different spaces, but it's not part of the diagnostic criteria, I guess. Rejection sensitivity can sometimes be seen in children and is commonly present in teens and adults with ADHD, some level of this. Rejection-sensitive dysphoria is a brain-based symptom of ADHD, and though the experience of rejection-sensitive dysphoria can be painful and even traumatic, it's not thought to be caused by trauma. In a recent study, 1/3 of adults with ADHD reported that rejection-sensitive dysphoria is the aspect of their ADHD that causes the most challenges in their life. So rejection-sensitive dysphoria is a heightened reaction to any level of rejection, whether that's real or perceived, that sends someone into like a really heightened emotional response to that rejection. So it's characterized by intense mood shifts triggered by either real or perceived experiences of rejection, whether this looks like withdrawal of love or approval or respect, teasing, again, real or not real, criticism, even if it's constructive, or persistent self-criticism or negative self-talk prompted by real or perceived failures. The person's mood can change immediately once their rejection-sensitive dysphoria has been triggered. If these triggered emotions are internalized, so again, there might be different ways this looks for different people. If we're an internalizer, the person can change immediately and instantaneously look like they are having a panic attack. They might be having those sort of intense, depressed shutdown. And this can even lead to really dark, depressing sort of elements. If people are having these feelings and they're externalizers, like they're outwardly experiencing rejection-sensitive dysphoria, this might be expressed as a rage at the person or situation that they feel has rejected them. And so these are the kind of people when they get to adulthood who might spontaneously quit their job because they feel like they've been rejected or insulted in a way. Whereas our internalizers are more likely to be like, oh, it's my fault. I've got to do this. I've just got to be better at this. I'm the problem. Sometimes externalizers can immediately sort of lash out at the other person. Many people who have rejection-sensitive dysphoria say it's always been a part of their life. However, they report growing significantly more sensitive in adolescence, which is already a really challenging time for our big feelings and our development. And sometimes for children with ADHD, this can be a time where this really becomes more apparent for them. People who have rejection-sensitive dysphoria might anticipate rejection even if they're not experiencing any in that situation. This can make them vigilant about avoiding situations where they might be rejected. So this might present as like avoiding making friendships or developing a bit of a phobia of social situations. They might develop people-pleasing strategies to avoid criticism or rejection, or they might avoid engaging at all in experiences where there's a chance they might fail or not be the best at something or fall short. Some people might become overachievers or perfectionists, and these are the kind of people that actually that might go a bit under the radar because they always seem like they're doing really well, but they might be have very low self-esteem or be very hard on themselves about any kind of failures. People who experience rejection-sensitive dysphoria can develop low self-esteem. They might struggle in maintaining friendships or romantic relationships. They might find sustaining employment challenging, and they might feel embarrassed or self-conscious. The suggested treatment of rejection-sensitive dysphoria and research around it is quite limited. However, I guess this therapists report that patients are often comforted just to know what is happening for them, that there's a name for this, I guess, sensitivity to real or perceived rejection. And after hearing what's going on for them, they are relieved to know that they're not alone. It's not their fault that they're like this, a bit like being diagnosed with ADHD probably. They might find relief with therapy or engaging in other things that build up their self-esteem and their self-worth, and having a safe person to talk to about feelings of rejection or sensitivity can be really important. Sometimes people might find in their teens and adulthood support through medication. Although rejection-sensitive dysphoria is yet to be recognized and included in the diagnosis, it's a term that's often spoken about in ADHD communities. You probably will come across it. The more you read about ADHD, you'll probably see it mentioned, and can be really important to be aware of as we navigate life alongside our ADHD child or teen. It can be a bit of a tricky element of ADHD. As I was talking about earlier, children who have ADHD often seem to experience really heightened emotions and have sensitive nervous systems. So research has shown that children with ADHD often have a smaller window of tolerance, which is, I guess, our window of feeling really good and regulated and capable of engaging, which means that children with ADHD may become over or understimulated more easily. They might go into that fight flight, that sort of outward externalizing presentation of dysregulation, or that free shutdown, that internalizing, really shutting down kind of presentation more quickly than their peers. We're going to talk about some ways to help with these things. So you might have come across this idea of the hand model of the brain before, and we can think of our brain represented by a hand. So at the base of our brain, represented by the wrist, is the brainstem. And this is responsible for things like sensory motor input and survival, keeping you breathing, your heart pumping. The thumb, which can be folded in the middle, is like the amygdala of the brain, which is important for sensing danger and telling the brain and body about that danger. And our fingers are like the prefrontal cortex, or the cortical brain, which is the part that helps us manage our emotions. That's where executive functioning sits in that part of the brain, and it helps us make that complex decision. That's our thinking brain. So when our child or we flip into dysregulation, when we're outside that window of tolerance, when we feel intense emotions, when we perceive fear or danger real or perceived, not real, we flip our lid. Our thinking brain goes offline because we don't need it from a survival sense. And it can be really hard when that's happening to make, I guess, cognitive or thinking decisions, thoughtful decisions, when we're really flooded with emotions. And so when our brains are overwhelmed like this, we need a break to be able to reflect and reconnect. And we might need support, particularly if we're children, to be able to get that thinking brain back online. Some ways that we can do this is using these 4 S's and 3 R's. So our 4 S's come from the work of Dan Siegel, and they are safe, seen, soothed, and secure. So when children have flipped their lid in any setting, it's really important that we are making sure we seem safe to them. We're using a calm, non-threatening voice. We're not singling children out or punishing them or anything like that. We're making them feel safe by our actions. We're making them feel seen. We're using accepting language, acknowledging and honoring children's emotions as real to them. And we're naming what's happening for them. We're making sure they feel secure. So we're using our warm approach when we set boundaries, and we can definitely still set boundaries when children are flipping their lid or emotionally flooded, to make sure that they know that we still care about them and they're still accepted, even if we're telling them they can't do something or setting a boundary or a limit. And we're being consistent in our boundaries and rules across all parents and caregivers in the family. Again, making sure that children understand, oh, this is the rules in our house. And soothed is about talking about what happened, acknowledging their experience is real, and giving children time and space to feel their emotion, and providing physical touch or affection if the child is comfortable or wants this. And then our 4 R's talk about how to meet those 3 areas of the brain. So what's really important first is to regulate or co-regulate with the child. We want to meet that brainstem's need, which is around making sure that children feel safe, and support them and meet their safety needs and say, I'm here with you. I'm not going anywhere. I'm here. I know this is really tricky. Then we can talk about relating and connecting to our child and acknowledging that what's going on for them and their emotions, which meets the needs of that midbrain or the limbic system, the emotional part of our brain. And then we can get to the reason part. And often as parents, when our child's having these big feelings, sometimes it's in like the most inappropriate place ever. And so we just want to go to reason. We want to make sure we can quickly say, hey, well, we can do that later. Oh, actually, you don't need to be upset about this because this is happening. But we know that when the other 2 parts of the brain, like our lid's flipped and our other 2 parts haven't had their needs met, it's really hard to hear that cognitive part and our reason part. So once our child is feeling safe and supported, their lid's starting to come back on, then we can do that sort of talking about, hey, let's reflect on what happened, let's learn, let's remember next time, etc. About social. So kids with ADHD can have difficulty knowing, I guess, what's important to focus on. And this can also challenge with social development and social skills. So they might have difficulty figuring out what details to focus on and zoom in on in social settings. Social settings are often unstructured, so kids with ADHD are even more prone to zoom in on unimportant things and miss the most important information in that social interaction. They can become easily distracted and fail to register important info at the moment. To others, this can come across as not interested. For example, if the child seems like they're not listening or distracted or they're looking off, people are just going to go, oh, you're not interested. I'm just going to stop talking. I'm going to move on. It can also lead children with ADHD to overlook context clues about what's expected in a given social setting. If they're focusing in on the wrong info or they're not picking up on those subtleties. Children with ADHD often struggle with nuance and making inferences and reading between the lines. That can be really challenging when you're not sure what thing you should focus on. Again, because their busy brains miss these more subtle elements of social interactions. They might need some support there. Impulsivity can lead to social challenges for children with ADHD and accidental mistakes. Being impulsive is often a central feature for people with ADHD. And so in social settings, this can look like lots of different things. For some, it may simply present as rapid fire speech, talking really quickly. There might be little room for others to respond in conversation. I know lots of times I've spoken to someone with ADHD, they are just talking, and I'm like, oh, when is it my turn? I'm sure people also feel like that when they talk to me. They might, cut in front of others in line or express ideas and opinions in ways that might seem rude to others. A really common experience of ADHD people is that they hear someone tell a story about something, and so they tell a similar story about their life, thinking that, oh, I'm cool, I'm telling you something that's a similar shared experience, but the other person might be thinking, all you do is talk about yourself. I just listen to what I'm saying about things. And so ADHD people might be sitting there going, oh, I'm just waiting for my turn to talk again. I don't want to forget what's in my mind. And so this can make it really challenging, particularly in younger children. Impulsive behavior can lead to difficulty sharing. You might see like physical aggression, for example, around this, very impulsive, and troubles with things like turn taking or waiting for your turn. This can lead to challenges developing and sustaining friendships. If your child with ADHD does have difficulty with any aspects of social engagement or making friends or anything that I've mentioned, it can be helpful to seek out something like play therapy to support with modeling and practicing these in a supported context without, again, as we said earlier, it's fine for you to have ADHD and find these things tricky. It can just be helpful, I guess, to have a space to practice and maybe become more aware of them without saying that you need to change how you are. Parents can also help by implementing consistent ground rules for behavior, like it's not okay to hit people, for example, around, or we need to learn and practice to take turns, and providing gentle and clear reminders as needed, and giving your child lots of grace and immediately sort of forgiving, oops, you forgot again, but that's okay. I'm here to remind you about that. Additionally, parents could facilitate play dates with peers, during which the parents take an active role in helping children practice and utilize their social skills and engage with the other child, like actively being there with them, modeling and playing. Although ADHD can present challenges in the social space, it's important to remember that kids with ADHD often possess many strengths that can actually help them be really great friends, succeed socially. Children with ADHD can be highly engaging, curious, energetic, creative, and open-minded. I really love working with kids with ADHD because I really find them all those things most of the time. And so this means with some extra support and empathy along the way, kids with ADHD can form really close, fun friendships and connections. They just might need a bit of help to get there. Another area of support that is helpful to mention is around executive function, as we spoke about earlier. As we sort of spoke about earlier, there's often a lot of negative messaging for people with ADHD and children with ADHD, and a lot of that is around this executive functioning space. We often assign morality to things that are around executive functioning. So when we see someone who's not able to stay on track, we might say, oh, wow, they're easily distracted. They're purposely, distracting others in class. Or if we find someone who finds it hard to keep their house clean, which is part of executive functioning, we might be like, oh my God, they're so lazy. All they're doing is not cleaning or not staying on top of anything. And so we often think of these executive functioning tasks as a sign of being like a good person, someone who's not lazy, someone who's on top of everything all the time. And so it's really helpful to change, I guess, how we talk about needing help with these things as sort of a neutral space. You might need help with this, but other people need help with something else, rather than, I guess, assigning morals or judgment on needing support in these areas. We can think of, again, needing support with executive functioning as going on a road trip with no map. You can see here, there's a graphic that talks about when a person who doesn't need support with executive functioning, someone's coming in. If someone doesn't need support with executive functioning, they can see the path to most everyday things and they know how to get their brain and body there. But people with executive dysfunction can't even access the stairs. They don't have the same journey as everyone else and they need help to get over that wall. You might see people talking about executive dysfunction and some elements of it as the wall of awful, like a real barrier to getting started with lots of things, or not really knowing how to get over it. Or you might see people talking about decision paralysis, really feeling frozen and stuck a lot of the time to know how to get started with these different executive functioning skills. As it says there's lots of emotional impacts of having executive dysfunction. It's difficult to predict outcomes for big decisions. So that's where that decision paralysis might come in. It's difficult to arrange the steps in your mind to be able to make an informed choice. So it's really hard to know what to do. It can be, can't hold working information in your memory to make you feel sure of anything. It can be really hard to make a decision there as well. And you can't imagine possible scenarios to plan for emotionally or practically. So you might be really anxious. It's really hard to actually know, like, what is it going to be like? It's really hard to picture. So some support strategies around this might be breaking focus time into short sections. So you might see this referred to online as the Pomodoro technique. An example of how this look might be 5 minutes focus, 2 minutes brain break, repeat. Because if getting going and executive functioning and having that wall of awful is really there, just focusing for short periods of time might be more achievable than trying to focus for a big half an hour block. You might break that half an hour block into 5-minute breaks. It can be really helpful to have a routine that avoids changes where possible. It's really helpful to give warnings before transitions. So giving a child 5-minute warning before you're going to go and do something else. It can be helpful to have visible reminders or timers, having visual timers or a visual schedule. And it's important to increase how often we remind our child of things. You might need to tell your ADHD child things more often as they can't sort of hold them in their mind or their brain's really busy. It's important to give short, clear instructions so that there's not all that, clutter happening in the brain, trying to break down all the things you've said. We want to break our tasks down into steps. And only give 1 or 2 steps at a time. And for each person, this will look different as to how broken down this needs to look. I use this app called Goblin, which you can type in, how will I clean my house? And it breaks it all down into these steps. And so it can be really helpful to utilize things like that. Go, actually, yeah, this is really good. I've broken this task down for my child. You can assist with task prioritization. So saying first you'll do this and then you'll do this. And again, remembering that capacity fluctuates over time. And so if you know there are times that are going to be really challenging for your child, like for example I gave earlier, where it's the end of term and they're really tired, you might not choose to do some really heavy things during that time that need a lot of executive functioning. Or you might go, you know what, actually, yeah, it's really hard for you at the moment to clean your bedroom. I'll give you a bit of a hand with that, or I won't be as cross if it's not happening as much. Because you're right, this is a time where it's really challenging for you. Some more strategies and ideas that are important, I think, are advocating against strategies that promote the idea there's only one way to do something, so that full body listening capacity and becoming that advocate for your child. Creating, where possible, environments that have lower demand or low demand, both at home and in educational settings. So extending periods of play or free time, having less transitions, having lots of opportunities for choice rather than whole group experiences. Supporting children to play and engage in ways that they like. So again, really embracing that neurodiverse affirming lens and saying, this is how my child likes to be, instead of maybe what other children are doing. Learning about children's interests, both for parents and for their teachers and people in their lives, showing interest in these and using these to create dopamine opportunities. As we talked about earlier, ADHD is thought to be related to dopamine, which is the hormone we get in our brain when we do something good or we get a reward. And so finding ways to talk about your child's interest can really create dopamine for them. And then, as I spoke about earlier, supporting development of interoception through things like modeling, use of self, like, oh, I'm feeling really hot. My body's really tired after we did that. Oh, your body's feeling that too. Cool. Naming what's happening for them, those emotions and those body-based experiences. Oh, your body is really running fast after we did that. It's really busy. I think the most important thing, if you take one thing away from this, it's about thinking about children with ADHD and all children, really. I give this message to everybody I work with, really, including teachers and parents, is that kids do well when they can, which comes from Ross Green's work. The foundation of this approach is realizing that kids do well when they can, and that kids whose behavior is problematic or challenging aren't being lazy or controlling or defiant or attention seeking or any of the other labels we might put on them. Instead, they have skills that need support, or they might have areas that need help from us. They need help acquiring some of the basic skills that come more easily to other children, which might include flexibility, adaptability, frustration tolerance, or problem solving. And so it's really shifting our mindset, everyone who works with children really and has children, from my child won't do this, which is that, I guess, that more judgmental, negative way of thinking about it, to they can't or they can't yet do this thing. We're being a bit more curious and open-minded about, you know what, it's okay that you can't do this yet. I can help you do this thing, or I can find the barriers and help and remove them with you, and helping our children feel really supported and strengthened by us. Here's a bunch of resources that you might be helpful to access after this, some of which this information has been drawn from. I would really encourage you, this is going to be up, this presentation, so you'll be able to see these again. You don't have to like write them down right now. But I would encourage anyone who's interested in reading more about ADHD or has a child with ADHD to access some of these. I think if I had to pick one or two that are the best, I would pick How to ADHD. I think that's a really helpful YouTube channel. I watched a lot of that when I was first diagnosed. And I also think NeuroWild, which is the cartoon and graphics, they're about ADHD and ASD, is also super, super helpful to understand different things about neurodivergence. They also have things like resources around how to tell your child about ADHD or autism, which can be really helpful. But all of these resources are really good. In terms of books, the top ones there are for adults. They aren't specific to ADHD, but they can be helpful books in general. And I also have a list there of picture books that are about having a brain that works differently. My Brain is a Race Car is specifically about ADHD, and the others are more specifically around just having different types of brains and that sort of, I guess, more broader concepts of everyone's brains work differently and people need different supports in different areas. So they can be really helpful to introduce that idea to your child or other people in your child's life, other children. They can be some really helpful books to start that conversation. These are our contact details. If anyone is interested and doesn't already have them, how you can get in touch with me and how you can get in touch with our practice more generally. I've made it before 9. Amazing. I'm going to stop sharing and I'm going to come back so I can see if anyone wants to ask any questions. But first, I'm going to stop recording.